We will now move on to our first panel discussion of the day. Our moderator for this session is the most erudite Dr. Manas Chatterjee. We welcome you to stage, sir.
So good afternoon, ladies and gentlemen. Before we sort of kickstart the panel, in very brief, if any of you have a question or a comment to offer regarding any of these three talks, you're welcome to do that before we start away. So if there's anybody who wishes to comment, or you can do that later as well. And during the panel discussion, if anybody of you, this is especially to the pediatricians, not to the dermatologists, have a question or a comment, please feel free to interrupt, because the meeting is for you and we want you to sort of, be assuaged with whatever queries you have. So we'll go ahead. I'll invite the panelists. We invite all the speakers, please. Sandipan, Dr. Maitreyee, Panda, Dr. Manjunath, and of course, Dr. Sudip Dash, Dr. Aditi Chakrabarti, and Koushik. So we'll have, we'll just have some questions which we'll address to the panelists. These questions are going to be sort of, they wouldn't be sort of addressed to any one particular panelist. Any of you can respond as per your convenience. So,
before you ask any question, so I just want to answer some unanswered question. Unquestioned answer, actually. On the other way around. Just look at your watch. We are running dot on time, right? Even some of the, best international conferences in dermatology, what my experience is, nowadays are not able to run on time. Even Indigo flights are also not running on time, as they used to do. But today we are dot on time. That is something which I wanted to share with you all. And that has been possible because of your cooperation and the cooperation of all the faculties. Give them a very big hand. All the faculties as well as to all of you.
Okay, we'll start. So this is going to be on the three talks primarily. And if there is any question which you've already addressed in your talk, just remind me. So we'll just skip that. So pediatric psoriasis. So anybody can respond, or from any one side, from Dr. Maitreyee. How common is pediatric psoriasis in your practice?
Sir, not very. Mostly the mild to moderate cases which I see. And it is like maybe in a week I see 1 or 2 cases of pediatric psoriasis as compared to adults, which we see regularly in a OPD. Okay.
So so it's actually second behind eczema. So that is, of course, the percentage is quite a bit different.
Manas, I think it differs actually.
Yes, Koushik.
Somebody practicing in a hospital where you have all kinds of patients, adult and pediatric. So there, as per the like a published material, we have 0.3% which are actually pediatric psoriasis. But when you are practicing in a setup where you see only pediatric cases, like in a pediatric hospital, so there the case is little higher than 1%, if I am not wrong, Sandipan. 1%, 1.4%, something like that.
Okay, this is a question, which a lot of pediatricians keep asking. Yes, sir, Sudip.
The thing is that with the data, what the state says that. Now, personal experience is different, as Koushik, I agree. If I am in Sandipan's hospital, in a pediatric hospital, data may rise. If in my hospital, many come to the pediatric department, they might not come to me unless they are referred. So that data varies in a large way. But what UK study, that is a study from UK, which showed that 0.55% is the incidence when it is below 9, and when it goes below 9 to 18, this data shoots up to 1.6. And there is another study, probably from Italy, which shows the data pediatric study is 2.45.
Okay, we'll go to the next question now. So any of you can take this. In a clinic, how will you distinguish psoriasis from eczema? This is something which pediatricians always sort of want to know. How would you distinguish that? So anybody can take that. Dr. Manjunath, yes, you can.
Practical tip is that the sites where we get to see eczemas are more common on the If you're taking atopic eczema, we know the common sites in infantile phase, it affects the face and extends us. And if the flexures are affected, that's more likely to be eczema. If the extensors are affected, it's more likely to be psoriasis. If something oozes, that is eczema. If it doesn't ooze, it's a psoriasis. If it scales more, it's a psoriasis. If it's more red, which is a salmon pink colored, it's more likely to be. Sometimes, you have psoriasiform eczemas and all that. But these are the simple things, a few tips for a distinction.
Yeah, probably nail involvement, etc. Yes, yes. I think the mic is.
Hello.
Yeah.
Another thing I always stress upon is the definition of the lesions. Psoriatic lesions
Are well defined.
very well defined. And of course, I think Dr. Maitreyee mentioned one can try the grattage test. It's very easy to carry on even in a busy clinic.
Okay.
One of the things that I want to help is the basic difference between adult psoriasis and a pediatric psoriasis. If you look at the morphology of the lesions are more flexural, maybe flexural, more of a greasy appearance, seborrheic. That is why seborrheic dermatitis comes in the commonest DD. And the third thing is that it affects the flexures and the facial involvement. That three things are already described in literature. And the second thing is that these psoriatic plaques of a pediatric age group are not only thin, they are also slightly erythematous.
Yeah, I think Dr. Maitreyee has discussed that difference between adult and childhood. But what I really wanted to ask Sandipan is the last thing which I've mentioned there, and that is psoriasis eczema overlap. Now that is an entity, that's something which we know very well. So could you just enlighten us on that?
Yeah, as very rightly pointed out by Manjunath and then Sudip, about how to differentiate between eczema and psoriasis. These points are very, very valid for all our pediatrician colleagues. Please, take these things into account while differentiating between these two conditions. But there are occasionally cases. Nowadays, the cases are on the increase because of several reasons, where we cannot make out a particular patient. In a particular patient, the lesions are whether they are psoriasis or they are eczema, and we have to recourse to doing a skin biopsy. So these are the lesions actually, where you see these are the patients. In some of the lesions, they are oozy lesions, crusted lesions, while others are extremely dry. Some of the lesions, there is hardly any underlying erythema, while those which are oozy or crusted lesions, that suggest eczema. But at the same time, in some patients, you will see the lesions are dry, scaly, underlying erythema is there. Or in the same lesion, this is called co-localization. In the same lesion, you will see early stage, it is the oozy lesions. Later on, it has become absolutely dry, like psoriasis lesions. So people have now, come up with an entity which is known as eczematous psoriasis or psoriasiform eczema for these lesions. And we know at the molecular level, going into the molecular level, there are a number of interleukin overlaps between, psoriasis and atopic dermatitis or eczema. Say, for example, IL-4, particularly IL-17. IL-17 is interleukin 17 is well known for psoriasis. But nowadays there is a lot of research going on interleukin 17
in atopic
dermatitis.
Yes.
Dada, Sandipanda, if I make it little simpler, like psoriasis and eczema, now sometimes in case of adult we write LSPS. Okay, LSPS. And in case of what you are telling is absolutely you have taught us eczematous PS, that particular entity. And why not psoriasis in atopic background? So that is one, definitely we write psoriasis in atopic background. Now, clearly, sometimes the disease, definitely they do not read textbook. But as mainly today our audience is pediatrician, we need to clearly keep in mind that both are dry. Not that this is moist, this is dry, not like that. Both are dry. Atopic dermatitis, these are also dry. But the thickness of the scale, what Madam told, that the delineation, the demarcation and the thickness of the scale, this is very very light, very fine and erythematous in case of atopic dermatitis or eczema. But here it is thicker scales, whitish scales, and clearly demarcated. So basically these are the things. Other things like overlap and all the complicating matter, inverse psoriasis that again complicates the matter, that again we can discuss some other day.
Okay,
Absolutely.
so we'll go to the next,
Agreed. Fully
question.
agreed, Koushik.
Remember, these overlap conditions do not respond to topical corticosteroid very well. So that's one point. I'm going to sort of skip this. I think I'll skip this as well. So because I don't think we'll get that much time. Okay. So I mean, I want to get everybody's view on tonsillectomy and psoriasis, because this is something which, again, something which a lot of pediatricians ask. So yes, anybody can respond to that.
No.
Yeah.
This is interesting actually. If you scan through the literature, the most of the literature, they are based on case studies. Now, Manas, as you are an erudite editor, based on case studies, we cannot come to a concluding point that whether this really helps. One, I could scan one randomized control study that the population, the study population is only 29, right? And there it is mentioned that yes, tonsillectomy has some positive effect on psoriasis. But I believe jury is still out, and as dermatologists, we cannot clearly come to a conclusion, you do tonsillectomy, psoriasis will be solved. It is not that kind of 1 + 2.
Yeah, so that sort of summarizes it.
So 2 points, The first thing is that, one thing is that there is a sweeping conclusion in one of the literatures published in Dhar, where a bariatric surgery completely cured psoriasis in an obese individual. Something is like that. Now, this is actually tonsillectomy doesn't cure, but if it is a gutted psoriasis and where it has been treated, probably it can help. So you need to know the type of the psoriasis.
Should we indicate tonsillectomy in psoriasis patient? What is the answer? Yes
So
or
that
no?
is it. The answer, I think,
Answer
is
is
what
no.
you've mentioned.
Answer is no, isn't it?
Probably, if the tonsillitis indicates a tonsillectomy even otherwise, suppose the patient has an indication for a tonsillectomy otherwise, that's probably going to be the only reason why you're going to do a tonsillectomy, not just because psoriasis is present. Yeah, so it's probably, I think this has been responded to. Yes, Abudi.
No personal, absolutely no personal experience, but just reading through the literature, I think there's a lot of study from Japan where they've shown that pustular psoriasis improves with tonsillectomy, and surprisingly, for tonsillectomy for plaque psoriasis has done better than for gutted psoriasis. And also they've said that in those patients whose psoriasis has been precipitated or flares up with the history of pharyngitis or tonsillitis, those are the ones who have done well.
Yes, so
Manas, actually there's another theory I forgot to mention, that autoreactive T cell hypothesis that I don't know much about it. You can help. Autoreactive T cell, they harbor in the tonsil. So if you remove tonsil, so this autoreactive T cell has some role in the pathogenesis of psoriasis.
Yes.
So, but again, if tonsillectomy is indicated from the tonsillar pathology concern, go for it.
Yeah.
But it is not so that if you have psoriasis, send your child to the ENT specialist for tonsillectomy and it will be cured. It is not that simple.
Sandipan, okay.
Yeah. From evidence-based medicine point of view, one single statement is that for psoriasis, tonsillectomy has got no evidence-based role.
Yes.
So tonsillectomy cannot be a panacea for psoriasis. In some cases, there are histories of recurrent pharyngitis and tonsillitis. The child is getting either, gutted psoriasis or pustular psoriasis, and there is a temporal correlation. There, you are fed up with treating with antibiotics and other, modalities. And tonsillectomy is a very safe procedure. There is no harm, particularly when the tonsils are enlarged, right? So you can take it like that. So it should be tailor-made according to the patient's need. There is no one single size which fits everybody. So this cannot be a sweeping statement that tonsillectomy is the cure for psoriasis. No, psoriasis has got no cure. I think that is a very important statement. you have to gradually tell your patients because patients have already read it from the Google engine.
Okay, so I think this has been probably, Dr. Maitreyee, you mentioned. So it's important to understand that nail involvement in psoriatic arthritis, that link is not there in children. Yeah, okay, I can actually ask this question to the audience.
Yes, Manas, there are some chocolates actually waiting
So
for
I
them.
think I'll ask this. So is there a particular...
There are some four chocolate questions.
Yeah, so
right?
this is, I haven't actually initially added this as a chocolate question, but I'll add it now.
So these you name as chocolate questions.
Chocolate question.
So they have had chocolate cyst during any training, but chocolate questions. Huh?
So a chocolate question is this: in psoriasis in infants, is there a particular morphology that you see which you will not see otherwise, which is not seen otherwise? Now you don't see otherwise so that actually the question has the answer. So it's a morphology which you don't see otherwise in any other age group, even in the pediatric age group. It's seen in infants. So what is that morphology, or which part of the body is involved with psoriasis in infants, which is not involved in people who are not infants?
You have to stand up and answer, and only one person will get chocolate. Because there is only one chocolate.
No, it's there in a lot of the pediatric age group. Huh? No, face can be involved. Anything else? So it's not involved in any other. That means it is not involved in non-infants. No. There has to be some reason for the involvement, remember. So think of infant, something which infants do which can cause, something which infants do, which other children will not do. Somebody like a 5-year-old, yes? Okay, so could you just repeat that? So sucking, but where will the psoriasis occur?
Lip.
Yeah, so say that loudly. So thumb involvement, you can give her a chocolate, please. But she's not a pediatrician. But she can get the chocolate. She's one of our IADVL residents.
Right. So you will get full chocolate or half chocolate?
So there are mics everywhere. You can come to the mic and I think respond. I think that's something which we got from the organizers. So key mineralization because of thumb involvement due to thumb sucking. Okay, I think this is a question he'll ask the panelists. So how would you distinguish pustular psoriasis from other pustular conditions in the child? Yes, Dr. Maitreyee, I think you can. Have you addressed this? No,
sir.
Okay.
No, sir.
Because that is something which pediatricians want to know.
Yes, sir. Sir, if you speak of drug reactions like the agape, which is also seen in the pediatric age group.
So these are the common, I've mentioned the common conditions, which are pustular conditions which occur in the pediatric age group. So the common ones and the less common ones. And so how would you distinguish each of these, or at least the major conditions?
So mostly what we see, if it is a generalized pustular psoriasis, then agape comes as the first, and subcorneal pustular dermatosis. These are the two most common differential diagnoses for a generalized pustular psoriasis.
So how will you distinguish pustular psoriasis from SCPD?
Sir, again we have to do some bedside procedures. Clinically it is not possible. Apart from the symptoms, which is more tender, there's an overlap feature, sir. Some patient will tell prodromal symptoms are more. Some patient will tell that the tenderness is more. So those subjective symptoms are not cannot be considered for the diagnosis. And another thing, background history of psoriasis, the nail involvement, and sometimes the joints involvement. What is important for a drug reaction is the prodrome period. So it can start suddenly or there has to be a temporal association of a drug followed by after which the acute generalized xanthomatous pustulosis can appear. the facial involvement in those cases is very, very profound. We see patients with facial edema, even in children, facial edema, follicular, non-follicular pustules involving the head and neck area. So that is a big key point in clinical diagnosis. But sir, again, it is an overlap entity. And other conditions which you have mentioned, like congenital syphilis, sir, we have to...
No, I have just marked some sort of important conditions, but...
Rather, sir, I would say cutaneous candidiasis is a very common confusion of pustular psoriasis, especially in the flexural areas. If cutaneous candidiasis is there, then you have to look out for the satellite pustules as well as the fringy border, then the patient giving a history and perianal involvement. So, sir, these are the clue points probably.
Manojda, can I come in?
Yes, please.
Because pustular psoriasis is now a total different entity with a new discoveries now.
Yes.
It is IL-36 in the iron inhibitors. So that without that you cannot diagnose pustular psoriasis. Pustular psoriasis is
And
totally different.
you have the card also coming
Now
up.
you have to think
No,
whether
card
it is-
14.
Whether it is psoriasis with pustulation, yes, for steroid withdrawal. That's a different entity. But pustular psoriasis de novo is a totally different entity. Now coming to the AGP versus pustular psoriasis, one thing should be there is a definite history of drug, what Maitreyee was mentioning. And the second thing is that AGP develops not later than 72 hours of the drugs. So it is mostly sterile follicular pustules. Whereas psoriasis is not only follicular, it's follicular as well as extrafollicular. It is both. Pustular psoriasis, if it is pustular psoriasis, it is both follicular as well as extrafollicular.
Any of the other panelists have any other observation, any other point? Okay, so Sandipan, now we have this, this card14 mutation form of pustular psoriasis. That's a new form which we now have. And of course the various other forms that is there. Now, which is the most common form of pustular psoriasis that you are seeing in the pediatric age group? Sandipan, which is?
Commonest form of pustular psoriasis, what we see in our pediatric age group, in our day-to-day practice, is the psoriasis with pustules actually. In most of the time what has happened that for the psoriasis lesions, topical steroid has been applied. And
what about the annular pustular psoriasis? I mean, that's something which I see quite commonly.
Yes.
It's
And
adolescent.
second, I was coming to that, annular pustular psoriasis. I have shown it umpteen number of times during my presentation on cyclosporin, that a young boy, 7-year-old boy, who was treated for nephrotic syndrome, was on steroid and developed multiple annular lesions with pustules, and it was treated as dermatophytic infections by our pediatrician colleagues with oral antifungals and topical antifungals also. It didn't respond. Then the moment the child was referred to me, a very renowned pediatric nephrologist of the city, Dr. Sushmita Banerjee. Sushmita sent this case to me. So I did a biopsy because immediately it was clear to me that this is a case of pustular psoriasis, annular lesions.
Because, I mean, this is something for the pediatricians. I think that is the most common form of pustular psoriasis, and it's the most commonly missed form of pustular psoriasis, as Shondipanda rightly mentioned. Okay, we'll go to the next question. Anybody? Okay. I think this is something which, Maitreyee, you've discussed, no? So we'll sort of skip this, and comorbidities, I think, was also discussed. So I've just remember one thing, this issue of mood, mood disturbances, that's something which is really, really important. And the ones which I have marked in bold are the ones which need to be monitored for. This is as a part of guidelines of the National Psoriasis Foundation and the Pediatric Psoriasis Comorbidity Screening Initiative. So this is a combined guideline which talked about these few things which are marked in bold, which needs to be monitored for in pediatric psoriasis, the common comorbidities.
Manas, actually in case of pediatric patients, the nail psoriasis, sometimes it's very frustrating for the person concerned, and there's no other lesion, only the nails are involved, and it is definitely very difficult to treat. And those patients also, like prognostically, they're not always good. Like they will develop the arthritis and other problems. So I think we need to discuss about the nail development, nail psoriasis a little.
Yeah, I think this is a very important issue Koushik has raised. Nail psoriasis in children. We have been increasing, our conventional concept is what? that nail psoriasis is uncommon in children. It is not as common as in adults. But there has been a paradigm shift over last few years now. We are seeing increasing number of nail involvement in children. I myself have got at least 25 children with nail psoriasis over last few years, 3-4 years I must say. And whenever there is nail involvement in psoriasis in a child, you can take it for granted that there is distal interphalangeal joint arthritis is a must. It is there. Maitreyee has shown in one of these pictures of the patient that there is already nail destruction and there is already distal interphalangeal joint arthritis. So you have to take it very seriously, and that is one of the indication of use of biologics, particularly which are very psoriasis specific biologics for nail involvement in the children. Because we used to earlier believe that methotrexate work for nail psoriasis, but it does not that much work. It works for arthritis, but not for nail. Particularly in children. This biologic is the only solution. But the issue is that biologics has got some cut-off age limit for some biologics.
So I've just put up this slide, which is the, one of the recent publications, which talks about the approved biologics and their age groups. So it's no more now only etanercept or adalimumab. So now secukinumab and ixekizumab are also EMA and FDA approved beyond 6 years of age. So that's, I just thought I'll sort of just flash this slide for all of us. So, so that's important. Yeah.
Sir,
So
I
this
would
is
like
my...
I'd like to add
Yes,
and
yes,
ask
Dr.
the
Maitreyee.
House that should pediatricians go for immunosuppressives in psoriasis?
We'll come to that. We'll come to that. We'll come to that. And that is a question for them.
Yes.
That is, what are the cases they would like to refer? Okay, this is the next quiz question. So what other drugs do you think you can prescribe other than topical corticosteroids, and you will get the, you'll get the chocolate if you mention at least, I want at least 4 to match my list. Other than topical corticosteroids. Could you come to the mic, please? Orpita has specifically instructed me to ensure that everybody comes onto the mic. So yes, so anybody can come onto the mic and just respond. So emollient's okay, tacrolimus okay, what else? So tacrolimus, you remember there are very specific indications. It's face flexures, so that is like a totally different ball game. So tacrolimus, actually I will not sort of specific indication wise, but emollients, yes, what else can you write? Yes.
Manas, if we just one point, if you just
yes,
allow me. Other than TCS, before that, I think it is better to discuss that what not to apply.
We'll come there.
Okay.
We'll come there. I think we'll come there. So I think with the pediatricians are drawing a blank, we'd request the dermatologists to tell us that what else the pediatricians can write other than topical corticosteroid, a low to mid potency topical corticosteroid. So what else can they write?
Definitely we can use calcineurin inhibitor, we can use the vitamin D analogs, we can use the bland, white paraffin, different kind of moisturizers, and now we have JAK2 inhibitors in topical formulations.
Do you want them to write the JAK inhibitors topical?
Why not?
Okay.
In case of...
Sandipan, you want them to write?
In topical...
Dada is in a quandary now. Ki bolbo?
Actually, now I'm doing a study on JAK inhibitors in pediatric age group on vitiligo.
So I feel, I've put up this list. I mean, I went through quite a bit of this thing. And I feel things such as urea, things such as urea lactic acid combination, maybe 3% salicylic acids, glycolic acid. So these are things which probably can be written. So I've just mentioned some. So what happens is we don't think of these common medicines. We only think steroids and tacrolimus. But you can write some of these things, urea, moisturizers, if you have itching, you can probably use some pramoxine, you can use some menthol, glycolic acid, etc. Okay, this is something which I want the pediatricians to say. What are the challenges that you face in the management of psoriasis? Okay, this is not actually a chocolate question, but I just thought I would want somebody, one person from you to sort of voice your views. What are the challenges you face when you are managing psoriasis? Could you just come onto the mic, please? Name and city, please.
Good evening, sir. I'm Dr. Sumana Chakrabarti from Dibrugarh, Assam. I have come a long way.
Please go ahead.
So the challenge in management of psoriasis, in my viewpoint, is diagnosing psoriasis. Whatever I have learned today in this last 40 minutes.
Okay, first is diagnosis. Fine, that's one. Next.
After diagnosis, I think even if I'm following the prescription of a fellow dermatologist, which I usually do because I am not managing alone, then is the point of keeping the patient coming back, because the patients lose hope so fast. The moment
okay, that is one. Next.
Sir, these are two of mine.
Okay, okay, fine.
Thank you.
So this is a list which I sort of could garner, and that is, of course, diagnosis you mentioned, that is always the first one. And of course, worsening, flares, etc. Patients, of course, sometimes aversion to topicals, etc. Again, the thought of using what kind of steroid, where you want to use it, etc. And of course, non-use of eyewear during phototherapy. I've actually seen this. I've known a pediatrician who did phototherapy without eyewear and managed to cause retinal burn. So that's something which is important. And of course, the use of vaccines when we're using biologics. So, okay. So this is the question which I wanted y'all to answer. When should a child with psoriasis be referred by you to us? So you can give me probably 4 points. So which patients of psoriasis? Okay, from the panelists, if there is a response, because I think the pediatricians want us to tell them when we should refer, they should refer to us.
On the first day. Because psoriasis is a disease which
I
is treated by us.
I've made certain points here.
I would
now tell me whether we are okay with this list. It's in front of you, Dr. Manjunath. It's in front of you.
Yeah, it's too little, smaller letters.
Actually, you can't read.
Yes.
Okay, so
I'll take very, very short and crisp. If it is an erythrodermic psoriasis, if it's a pustular psoriasis, if it's a widespread psoriasis, please refer to a dermatologist.
Arthritis.
okay, so I have put up some points. You can just sort of just quickly read it. I wouldn't sort of. Okay, this is a question for the pediatricians actually. So how frequent? Just one response from any one pediatrician. So how frequent are skin findings in the neonate in your practice? Any pediatrician can sort of come and answer that.
Almost 60 to 70% of newborns, they come with normal physiological conditions.
Okay. So this is as per the literature. So it's very, very common. What I wanted to say is really, really very common. I think I'll sort of skip that. The neonatal skin is more prone to infection, irritant, dermatitis, etc. This is a question which I wanted to ask the dermatologists. How would you distinguish? You see, we get to see cutis marmorata quite frequently. How would you distinguish it from the other mimics? We all know those mimics. So how would you distinguish this? Because this is something which is important for pediatricians, because some of these conditions are associated with connective tissue disorders, systemic diseases, etc. So anybody can take that on.
I would like to take it up.
Yes, Dada.
Okay. See, basically cutis marmorata is by and large a benign condition. It more or less disappears on its own within a period of 2 to 3 months. But if you see that along with this cutis marmorata, there are lots of telangiectasia around, and it is persistent beyond 3 months, and some of the lesions are showing changes like vasculitis, you must have to consider cutis marmorata telangiectasia variety, which is a bit severe condition. There can be livedoid vasculitis in older children, which mimics cutis marmorata-like things, and slightly even older to adolescent to adult patients, presenting cutis marmorata-like lesions, maybe erythema abyegni also. So there you have to take the history.
There is a history. Erythema abyegni, in fact,
yes.
in Ladakh, I used to see a lot of them.
Right. And now here I would like to make another statement which is very important for all of us to, just keep it in mind. That it was asked that how frequent is the neonatal skin changes. Let me give you one statistics that India's population is the second highest in the world. Okay, next to China.
Now first. After
We are first,
after
Dada.
April 23rd, it is number one.
Number one. No, huh? Okay, good.
Numero
okay.
uno.
This I didn't know. What has happened recently? Okay. But India's pediatric population is over last more than 10 years is number one in the world. Because below 16 years of age, 31% of the pediatric population in India's pediatric population, and skin lesions pediatric patients presenting with skin diseases in the OPD, standard OPDs in children hospital and otherwise general hospitals is by and large 40%. So we can imagine the volume of pediatric dermatosis in our country. It is 4 to 5 times that of USA and 4 to 5 times that of entire Europe.
Thank you, Dada. So this is the question again for the panelists. So neonatal acne versus benign cephalic pustulosis. Is there a distinction? Is it important? And how would a pediatrician make out that difference?
I just thought the previous question, I just add one point.
Yeah, please go ahead. Please go ahead, Dr. Manjunath.
In libido reticularis or libido racemosa, these are the conditions which can easily be mistaken with cutis marmorata. Number one, the network will be incomplete in these conditions.
Yes, so
cutis
racemosa is very important point. Libido racemosa is incomplete.
Network.
That's a very
Number
good
one.
point.
Number two, there won't be ulceration. Ulceration will never occur in marmorata. Number
Yes.
two. Number three, persistence, which
Reversibility. So reversibility is very
this
important.
Is persistent. This is persistent for
And
months
it's
together.
minutes to hours. The reversal happens in cutis marmorata in minutes
And
to hours.
if there are systemic symptoms, for example.
Absolutely, very good points there. So yes, so somebody can respond to this. Benign cephalic pustulosis, how will you tell the pediatricians to be, and is it important?
Sir, I think this is absolutely a physiological condition. So there is nothing which, more of counseling.
What about
sir.
benign cephalic pustulosis?
Sir, this is again a physiological condition. Only a bluish appearance there may be a trace of background pigmentation. Sometimes these conditions.
Now this patient with benign cephalic pustulosis, Dada, can it be easily mistaken for neonatal acne?
Yes, sir.
Yes. So what is the difference? So that is important.
Absolutely, because difference is that benign cephalic pustulosis, which is basically a hypersensitive reaction to malassezia purpura.
Yes, Dada. Yes, Dada.
So you see lot of erythema in the surrounding lesion, which I showed in case of neonatal acne. There was hardly any erythema in the surrounding lesion. You see here there are 1 or 2 pustules, but there is a huge area of erythema. That is basically hypersensitive reaction to malassezia purpura, which you do not see in neonatal acne.
Thank you, Dada. So, and the other thing, of course, the lack of comedones.
Comedones and...
The lack of comedones here is very important.
Yeah.
Yes, sir.
Acne is like, it's a polymorphic disease. You do get to see comedones, you may see papules, pustules, even in neonates. The one thing I would like to mention about neonatal cephalic pustulosis is, apart from it being hypersensitivity, you can actually demonstrate a malassezia purpura from the pustule. There's a beautiful picture in NEJM clinical images this time where they have demonstrated the malassezia in the pustules from the forehead.
So I have just got this from in fact, Sandipan Institute. This is a publication from PGI, which is very interesting. I mean, it's very, for clinicians, it's very good because it's neonatal pustular conditions given week-wise. So, I really like this particular method they've used to sort of delineate it. It's for all of you, you can just sort of have a look at this and maybe take a photograph. So week-wise, what are the most common neonatal pustular conditions that you would see? So that's what I thought. I'll just put this up. Are we done? I'll just go to the next one. Because it's a conference for y'all, so y'all should sort of be going happy from here. Are we done? And I'll show you a couple more. One is this, evaluation of pustules in a neonate. So they have actually divided, from the same publication, they've actually divided into systemically healthy versus systemically unwell. So these are the common clinical features and the evaluations and the diagnosis of the common conditions where the patient is systemically healthy, the neonate is systemically healthy, and this is the one where the neonate is systemically unwell. So probably this is more relevant to you all as pediatricians. So how you will sort of, and you can go through this publication, it's of last year and published in the IJDVL. Yeah, so this is a question for, they will want to know the answer to. How would you distinguish vitiligo, nevus anemicus, ash leaf macule, nevus acromicus? How would you distinguish? It had, I want one of us to respond to this. So anybody can respond to it.
I think the first thing to remember is vitiligo, the lesions are depigmented, in contrast to the hypopigmentation that you see in the other conditions. That's the first thing. So depigmented, always think of vitiligo.
Ash leaf macule also looks very white.
No, they may look white, but they're not depigmented like vitiligo.
And the shape probably.
Hypopigmented. Yeah, ash leaf macules, the shape, the ovoid shape or the lanceolate shape of ash leaf macules. Okay. Between nevus anemicus and nevus depigmentosus, do a dioscopy, press a glass slide around the margin of the lesion. If the margin fades, it's nevus anemicus because that's a pharmacological nevus. Because of circulating catecholamines, they are very constricted. So if you press, it disappears. Nevus depigmentosus, well, it's hypopigmented. It has a sort of irregular margin. And the other thing is if you have access to a Woods lamp, a vitiligo lesion will show a chalky white, it will appear chalky white. The others also become more prominent. And ash leaf macules often, even if you don't get to see them under Woods light, they may become more prominent.
Anybody has anything else to add to it? Otherwise, we'll just go ahead. This is, of course, a nevus acromicus image.
Yeah, vitiligo expands. Rest all the conditions are static. They only proportionately grow as the child grows. That's one.
Yeah, okay.
Manas,
fine.
can I
Yes, Dada,
interrupt? No,
yes.
not related to this, but something else.
Yes, Dada.
Which is very important for all our participants, particularly pediatrician colleagues. So often we have been seeing that in the prescriptions of fungal infections or intertrigo, you people are writing, I'm not specifically telling you, so a lot of others are also writing, internist, GPs, topical combo of steroid antifungals. Please don't do that. Repeatedly been told by Dr. Manjunath Shenoy. We from IADVL, our Indian Association of Dermatologists, Venereologists, Leprologists, which is the second largest, dermatologic society in the world. Still second, no?
Yes, after AD, I think.
I was thinking, and just like China, probably we have become one.
Will be number one.
China, maybe because of Galo and many Chinese.
That is when Koushik becomes president.
So, second, there is a movement which has gone up to Health Ministry, and there are going to be very strict, restrictions of use of it. And for this huge movement, there is a team, and the torchbearer of the team is none other than our own dear Professor Dr. Koushik Lahiri. So I request Koushik to tell, what exactly to be done about that.
I'll be very crisp actually, because we have not discussed any dermatotherapeutics today. It was decided that we will not discuss any treatment. But I think it is important, ultimately at the end of the day, from tomorrow again, you will go back to your clinical practice. And again, dermatological cases will come to your clinic as well. Now, be very clear that... Sorry? Yeah, and be very clear that what is the least potent topical steroid and what is the most potent topical steroid. So the least potent is definitely hydrocortisone and this desonides, and the most potent is clobetasol. And very close name is clobetasone, which is actually in the least potent category. So there is sometimes a confusion between clobetasone and clobetasol. So please remember not to use clobetasol in your target population, the audience or the patients. And number two is any molecule like fluticasone or mometazone. If the base changes, the potency changes. Fluticasone in cream base in pediatric population is perfectly okay. But the same fluticasone, when it comes in an ointment base, it is definitely potent. And please remember not to use any potent corticosteroid in the opposing surface of a baby. So these few points, I think, from the panel of dermatologists with folded hands, and what Dr. Manjunath repeatedly tells, there is no scope of adding any topical corticosteroid in any fungal disease. If you have diagnosed that this is a tinea, a fungal infection, please stick to antifungal topical, or if you think systemic, you can add. Do not add any steroid at all. So these are the few points that I think it is needed to
And I'll just add one thing. Mometazone, all of you write it. Mometazone is a potent topical steroid. It is not a mid-potency. A mid-potency is something like a fluticasone, not mometazone. So that's just one addition. Okay, so this is one quiz. So how will you distinguish a vascular malformation from a hemangioma? Hemangioma versus vascular malformation. This is simple. I thought somebody can, yeah. You can go to the mic. Right behind you. The mic is right behind you.
Vascular formation are bluish color and hemangioma are usually reddish color.
No. You can have a red vascular malformation.
Manas, there is a lecture by Dr. Sahana P. Raju.
Okay, I think we'll go ahead. Okay, I think we'll then.
On hemangioma, you please.
Okay, I'll. Okay.
Right.
Okay, does erythema toxicum neonatorum, Sandipan, this is a question for you because you mentioned it. Does it have any connotation in terms of, suppose somebody has got erythema toxicum neonatorum, is there an implication for that to the child's future?
Yes. Very, very important question. Manus, you are reading pediatric dermatology a lot nowadays, I can see. So, erythema toxicum neonatorum by and large should disappear by 4 to 6 weeks. Usually it disappears by 2 to 3 weeks. But if it persists beyond 3 months, if it is very severe form, if the child has associated features of toxicities or features suggestive of photosensitivity, it can be a manifestation of neonatal lupus also.
Okay, and one more thing which I found out was this, and that is atopic dermatitis. There seems to be an association of this condition with atopic dermatitis.
Right.
The next question. So this is the last of the 3 lectures. So so this is for the pediatricians. So what is your view on the use of topical antibiotics, because something which, we all write, to prevent bacterial skin infections and for promoting wound healing. We all do it. We do a biopsy and you give a topical mupirocin following an uncomplicated minor wound. And which are the exceptions? I want to know the exceptions. Where can you use a topical antibiotic as some kind of a prevention? Chocolate question. Sir, could you please
talk to the microphone, please.
And the baby is in NICU and higher antibiotics, and a preemie baby or very low birth weight baby.
Can you introduce yourself, please? Name and city.
So would you use a topical antibiotic?
In case if the child is developing some pustule and the child is
already... But the child is already on high-end systemic antibiotic. Why would you use a topical?
Definitely we need, in case of preemie or a very low birth weight baby, we definitely use topical antibiotics.
Okay, could we get another response, please? Yeah. Something which is evidence-based response.
I am Dr. Himanshu Kelkar from Indore.
Thank you so much, sir.
Thank you, Dr. Kelkar.
Anybody else? The chocolate is still available. So any of us can respond to that. Anybody can respond to that. Where would you use a topical antibacterial as a preventive?
Yes, there is a very established indication of use of topical antibacterial. So much so that it has become. Don't bother about the time. You will get 5 minutes more time. I am giving you 5 minutes more, right? So this is called mupirocin prophylaxis. There is so much of data on it. A child getting recurrent bacterial infection, a child getting extensive papular urticaria, a child getting recurrent flare of atopic dermatitis. Since Staph aureus colonization is one of the very important factors, people have given topical mupirocin over the anterior nares, external auditory meatus, and perianal areas for 6 months to 1 year, and they have seen that the severity, flare-up of atopic dermatitis is reduced. And subsequently, copying mupirocin, people have done trial with topical fusidic acid also. So there is fusidic acid prophylaxis also, apart from mupirocin. But mupirocin studies are more robust, more huge in number. So that's why it has become almost synonymous. In fact, the pediatric dermatology textbook also writes mupirocin prophylaxis.
Thank you, Dada. Thank you. I think I'll skip this and go to the next question. Yeah, this is a question. In fact, I was just talking to one of my students.
If somebody wants to ask any question, please don't raise your hand. Come to the microphone.
Okay, you can respond to that.
Just throw distance from you and stand there and start talking.
Sir, I just wanted to quickly ask you a question on the follow-up that you were talking about the topical antibiotics. What's your view on the aminoglycosides in that series that you talked about? So you talked about mupirocins and fusidic acid, but is there any place for aminoglycosides in the topical?
Dr. Manjunath, it is
topical aminoglycoside.
You're talking about fluoroquinolones, I think. Probably. Which one you're...
Aminoglycoside? There is...
Sir, famacetine, so neomycin.
Gentamicin, see, now they have become yesterday's antibacterials. Nowadays, they are not used at all. In fact, I think more or less they are discontinued. They are only available with the topical corticosteroid. Alone, they are not available.
So there is a high risk of sensitization, and that is the problem with these agents.
Dr. Gautam, please come to the microphone.
So are you talking about prophylactic use? I'm talking only about prophylactic use. So, so that's not a part of this question.
General question that ofloxacin preparation has come out with topical antibiotic form. Can we use that?
That is why he mentioned fluoroquinolone.
It's absolute unscientific.
That's why he
even
mentioned
if it is coming, it is unscientific. See, ozenoxacin is available and nadifloxacin is available. These are the two which have evidences behind them to be used as antibacterial in primary skin infections. Other than that, ofloxacin, they are all available, we know. In India, everything is available. And they are all mixed up with the topical corticosteroid, antifungals, various things. But they are all unscientific. They are all getting state GCGI approval. Somehow they are bringing it to the market and they are pushed into the pharma. Most of the time, they are sold over the counter. But I think as a qualified dermatologist or a pediatrician, we should never use.
Thank you, Dr. Manjunath. So it's always good for you to ask these questions because...
Good message, loud and clear.
Yeah, so this is again a quiz question for all of you. So there is one drug, I'm not talking about steroids, etc., which in certain publications have been, it was a surprise to me actually when I read it, has been known to increase the risk of developing necrotizing fasciitis or the development of progression of streptococcal necrotizing infection. Which is that agent? Which is that drug? So again, there are a little bit of controversies in that as well, but I was surprised to see the name of that drug being mentioned as one agent which could increase the risk of necrotizing streptococcal infection. Anybody? Anybody from the panel can also get a chocolate here. No, immunomodulator will know. So NSAIDs actually. So it's been, and this is a systematic review and meta-analysis. Don't forget that. So I've put that reference at the bottom. NSAIDs and the possibility of association of development and progression of streptococcal necrotizing infection. So that's, it was a surprise to me when I read it because Sandipan gave me this job, so I was reading a lot of pediatric dermatology in the past 1 week or so. Okay, yeah, this is...
I'll request you to close it in 1 more minute. Huh?
Yes, Dada. So this is a question which again I want the dermatologist to sort of mention it because I'm sure this is something which is going to be interesting for pediatricians. So this is regarding pediatric asymptomatic leprosy contacts.
The guideline now says is to give a single dose rifampicin depending on the age of the patient and the body weight.
So that is it. And of course, even people have mentioned BCG vaccine, which is of course used in our country on a regular basis.
The guideline says single dose rifampicin.
Yeah, absolutely. But again, regarding single dose rifampicin, there are some studies on to sort of revalidate it because there are some controversies. But Didi, as you rightly said, that is currently
being implemented actually.
2018 WHO guidelines, and that what Didi has said is the absolute correct thing. So I think this is something which all of you can sort of do, at least till we get something new.
In our country, it's BCG at birth anyway. Everybody gets BCG.
Yeah, so this is another question which I want us to sort of address and, kill this point about topical antivirals.
Absolutely no role. A lot of people use it when
That's
they
why
see
I put this question.
herpes infections. It has absolutely no role. Probably the only small role is when there is recurrent herpes infection and the person is able to tell in the prodromal, there's prodromal period and people are able to say that they are about to, develop herpes lesions. Maybe at that point of time it is applied. It may decrease the severity of the lesions or even abort. But other than that, in active lesion, there's no role whatsoever. Maybe only for eye.
Dada, last response from you, Dada. I think we'll close this.
One single statement is that topical acyclovir has got no role.
Thank you, Dada.
No herpetic conditions.
Thank you, Dada. And this is, I think I'll just sort of... Okay, thank you, ladies and gentlemen. I think we'll...
Thank you, Manas, for a wonderful moderation once again. Very exhaustive, thorough, and, some of the questions were really very tricky.